Hello, Dr. Takahashi.
Hello.
Okay, you should be able to share your screen. Thank you everyone for joining us. I would like to introduce to you Dr. Ayami Takahashi. She'll be presenting for the Rural Opioid Prescriber Training Program webinar series, and today she will be presenting Adolescents and Substance Abuse, Clinical Observations and Strategies for Engagement. Following the webinar, you will receive an email with a link to a short evaluation. You will need to complete the evaluation to claim your credit, and the link will be active for 30 days only. So after that time, you will not be able to claim your continuing education credits. So now I would like to introduce Dr. Takahashi. She has been with SIU since 2006. When she came to SIU, she started a new child and adolescent psychiatry training program. She is board certified in general psychiatry and child adolescent psychiatry, as well as board certified in addiction medicine through the American Board of Addiction Medicine. So please welcome Dr. Takahashi. And are you able to share your screen?
Okay, I'm going to try now.
Okay.
Okay, here we go.
If you can't, I can.
Yeah, looks
There we
like
go. Perfect.
Okay.
Perfect. Great. Thank you.
All right. So this is a lecture about basically working with adolescents. We won't really touch on opioid use so much because this is really more about how to engage adolescents and maybe some observations I've made clinically over time in working with teenagers with substance abuse issues. So I have no financial relationships with any pharmaceutical companies or other medical device organizations, etc. So the goals and objectives of this discussion is first to identify the different stages and types of substance abusers, learn about some screening tools and other signs for early detection, and also to learn about some ways of engaging adolescents into treatment. So just think in your head, complete the sentence. Adolescent substance abusers are blank, fill in the blank. And think about it as I progress in this discussion. So first of all, it can happen to anyone. So the Monitoring the Future survey is a survey that has been done every year of 8th graders, 10th graders, and 12th graders throughout the nation. And I believe it is done through the University of Michigan, but they publish the results on drugabuse.gov on a yearly basis. And they have all sorts of statistics. Now for this first slide, I've just used the statistics of they've used in the last 30 days. And in the subsequent slides, it's used within the past year. So I wanted to make that distinction. So alcohol use is by far the highest percentage. So as expected, 12th graders have the highest percentage of use. So about 33% in the past 30 days, they've had a drink. 10th graders, about 20%, and then 8th graders, about 10%. And for cigarettes, 12th graders, about 7.5%, 10th graders, 3.2%, and then 8th graders, 2.2%. Cigarette use has actually gone down quite a bit over the last 10 years. But instead, what's happened is the vaping has skyrocketed in comparison. So this is all vaping. So it includes marijuana as well as nicotine in terms of what they're vaping. So 12th graders, almost a third, have been vaping. 10th graders, about a quarter. And eighth graders, it's a little over 10% have been vaping. And that's been the biggest concern, is that if you look at the cigarette smoking, they're not smoking a lot of cigarettes, but they are vaping quite a bit. And I think there may be this misconception among especially the middle schoolers that vaping isn't quite as addictive. But it's equally addictive, especially, you know, with the nicotine, because nicotine is probably one of the most highly addictive substances out there. And then I don't really talk about this much in this particular discussion, but what they found recently is that people who start vaping early tend to, in later years, smoke cigarettes as well as vape. So it's not really protective against anything. So this is a slide from NIDA, the National Institute of Drug Abuse, which shows the perception of marijuana. So basically in 93, you have about 26% of teenagers using, whereas 35% feel it's harmful. And then if you go through the years, the yellow, the perception of harm has been going down. And then as the perception of harm goes down, the use goes up. So this is quite a few teenagers who have used in the past year. So this is 12th graders. So over 30%, and this was back in 2013. Now there's some decrease, especially in the stats over the last couple of years, but one thing about the 2020 survey results is because it was the year of COVID, they didn't get as many of the survey results back because many kids weren't in school. And that's where they conduct the surveys. So another slide from NIDA, 60% of high school seniors did not view regular marijuana use as harmful, which is doubled from about 20 years ago. However, the potency of marijuana, as measured by the THC content, has steadily increased over the past few years. So the daily use of today's marijuana has greater health consequences than the marijuana of 10 to 20 years ago. And this is information that you can let teenagers know when they tell you, well, it's natural, it's an herb, etc. It's not so natural. People have tinkered with it to the point where the psychoactive component is doubled from the time of, say, their parents' marijuana. So some stats for prescription drug use. This is among 12th graders, and this is all use in the past year. And this is also using prescription drugs that were not prescribed to you. So Adderall abuse was about 4.4%, Vicodin about 1.2%, cough and cold medicines 3.2%, tranquilizers about 1%, OxyContin about 2.4%, and Ritalin about 1.7%. And this actually shows an overall decrease from a few years back. And this is illegal drug use or illicit drug use amongst 12th graders. And again, the stats are for in the past year. So 21% in this particular survey, spice 2.4%, MDMA 1.8%, so about 2%. Powder cocaine close to 3%, crack cocaine about 1.2%, methamphetamine 1.4%, and then heroin 0.3%. So if you, so heroin use among teenagers is still pretty low. I'm gonna go back to the previous slide real quick. If you look at, say, OxyContin use, So these are the prescription pain meds, and Vicodin. It's higher than the heroin use. So typically teenagers, when they use these medications, are getting them out of their parents' drug cabinets or their grandparents' drug cabinets. Heroin use is still relatively rare among teenagers, or at least the young 18 and under. All right. And then if you add all of the stimulant use here, so it's actually slightly higher in terms of abuse than the prescription Adderalls. Typically, what I see in the clinic is that kids who are prescribed the stimulants in high school, many actually report other kids offering to buy a pill off of them here and there. Most do not, however, in a pinch, some will sell a pill or two. And so that's where you have to be careful when you have kids with ADHD that you're prescribing stimulants to. So these are the typical stages of substance abuse. Well, of course, stage 0 is no use at all. Experimental use, that's fairly common among teens, where they maybe use once or twice and they don't get hooked on it. Then there's regular use, then problem use, then it becomes substance abuse, and then progresses to substance dependence. So screening in the office, these are fairly common screening tools. Now the CRAFT is an easy one. It's kind of like the CAGE screen for adolescents. CAGE, I think most of you are probably familiar, is the quick and dirty screening for alcohol abuse. But the CRAFT screen, which I'll go over into greater detail in a minute, is very useful for screening adolescents. There's also the drug use screening inventory for adolescents. Now that is a 159 item questionnaire. It's free, but you have to write to the authors to obtain it. And then there's the POSIT. That is developed by NIDA, and it's free online, and it has 139 questions. So really, the more questions you have, you may or may not get complete answers from people, but these are available. So CRAFT. So this stands for, the first C stands for car. And the question is, have you ever ridden in a car with someone who was high? And that would be including the teenager that you're talking with. And then the R is relax. Do you ever use drugs or alcohol just to relax or fit in with others who are using? And then the A is alone. Do you ever use alcohol or drugs alone? And the first F is forget. Do you ever forget things you did while using alcohol or drugs? And then the second F is for family/friends. Do your family or friends ever tell you to cut down on your use? And the T is for trouble. And have you ever gotten into trouble while using? So this is pretty comprehensive, with parents, with teachers, with girlfriends, boyfriends, etc. So basically, if someone answers yes to 2 items on the CRAFT, it's considered a positive screen. And if they answer yes to the car question, and that's the only one, that's still considered a positive screen. And so you would do further assessment and get more detailed information and do education at that point. Although you can still do education regardless, which would be encouraged. So these are some of my clinical observations on the types of adolescent substance abuse. So, and these are actual quotes from some of the patients I've seen over time. If someone told me you could get high from poison ivy, I would probably try it. So these are the kids who are somewhat thrill seekers. They very frequently have untreated ADHD, have high impulsivity. Frequently you see family loading, but not all the time. And then more of the polysubstance users fall into this category, and more people with possible conduct disorder as well, because it's not thrill seeking just with drug use. There's thrill seeking in multiple domains. So these are the kids who want to try everything and have probably tried everything more than once, but don't necessarily get hooked on one drug. It's also relatively rare in adolescents because the length of time in use is a lot shorter. You don't see as much physical dependence on any one substance, although sometimes you do see it. And then there's the anxious or depressed types. These kids tend to gravitate more towards marijuana, as it seems to have a calming effect and temporarily can relieve depression, although there's more and more evidence that with chronic use, you make anxiety and depression worse. Many, again, may have untreated ADHD and a lot of sensory issues, which the marijuana seems to calm down. The other thing with marijuana is it does boost dopamine. So if you have really bad ADHD and you're very hyperactive, it actually does calm down hyperactivity. And so a lot of kids describe almost self-medicating ADHD with the marijuana, and then over time they become less motivated and they stop going to school anyway. So then there's the traumatized group. So these are the kids who've had multiple early traumas, abuse histories, and they may be self-medicating for, again, depression as well as post-traumatic stress disorder. There's a tendency to prefer downers. So marijuana, alcohol, benzos, and then, you know, the pain pills as well. Then there's also another subtype where there's the culture of use in the family. You see this especially with marijuana, but I think you also see it a lot with alcohol use. It's always around. The use tends to start young, even as young as age 8. And I've seen some kids in rehab that were mystified that, you know, mainstream culture thought the use was wrong because it was just around all the time. Parents were doing it, siblings were doing it. And so I don't do drugs, I just smoke weed is kind of a common sentiment. And that particular sentiment has gotten even more prevalent since the legalization of marijuana in multiple states. And you do see kids younger and younger smoking it as well. So how to engage adolescents in treatment, which can be very difficult. So I don't know why you keep blaming my friends for everything. I am the one who wants to get high. So this was a quote from a teenage girl to her mother, because her mother kept trying to restrict her from her friend group. And she was desperately trying to let her mom know that she was actually the bad influence, not the friends. And there's no question that the peer group does influence each other. But the important thing is to understand why. And I have had kids tell me that they hang out with the quote unquote druggies because they're just more accepting and there's less social pressure than other groups in the school. And so the kids who are depressed or have had, traumas may feel that this is a much more accepting and maybe have common things, things in common with them. And that's why they have this particular peer group. This is kind of the common misconception of how kids get hooked on drugs. Be smart, say no to drugs. There's this two innocent looking kids and an adult with a bag of pills saying, here you go. But that's actually not the reality. So this young lady will take any pill her friends give her, but won't take anything her doctor gives her. And this is fairly common among adolescents, right? Where they trust their friends a lot more than they trust adults. So some of the barriers to engagement in treatment. So remember the developmental stage of adolescence, there's quite a bit of grandiosity. They think they know better and that the adults know nothing. And so you have to be aware of that when you try to engage adolescents in terms of getting them to buy into treatment or buy into the fact that they may have a problem. So this is, if you go at it in an authoritarian manner, this kind of illustrates the sort of response you'll get. So what we say to dogs, okay, Ginger, I've had it. You stay out of the garbage. Understand, Ginger, stay out of the garbage or else. And what they hear, blah, 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 Ginger, blah, 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 blah. And that's kind of the response you'll get from many adolescents if you try to lecture them. So we need the buy-in of parents to get kids into treatment as well. And that can be a barrier, especially I've had parents who were very reluctant to even talk to their adolescent about stopping marijuana use because their kid was just calmer and they didn't want to get into arguments about it. And then, availability of resources, of course, is an issue as well. Especially if you're from a small town and there's not much around, they may have to travel to get treatment, and that can be a huge barrier for some people. So the different options that are available, some treatment is better than no treatment. There are the 12-step groups, so that's like AA, NA. Teens typically don't like them very much, but again, some do very well with them. And some of what they complain about is one, their spiritual focus. Some don't really buy into that. The other thing is 12-step groups, they talk about, guilt and reparation to people they've hurt. And the thing is, teens typically don't feel very guilty when they use. And in terms of reparation towards others, if there is family chaos as a contributor toward their use, frequently the teens are very much in the mindset of blaming others. So they're not in that state yet where they're as introspective and able to work the 12 steps in the way that adults are able to. But again, some teens are very mature and they are able to work the 12 steps and they find it very helpful. Motivational interviewing, SBIRT is screening and brief intervention and referral to treatment. So that is doing brief interventions in very small doses, even in the emergency room. And they found that this actually can be effective. So giving little educational nuggets, having them consider, well, what's the pros and cons of using and not using, and gently nudging them toward accepting that perhaps quitting would be the best course of action. So there are residential programs, there are public and private programs. Of course, the private programs are much more expensive. And public programs tend to have a pretty large wait list, although places like the Gateway Foundation and the one in Champaign, I'm blanking on the name. That one, I think the turnover is relatively rapid, so that, you know, if you get yourself on the wait list, you can get in within a few weeks, I think. Rosecrans is another one. And then, you know, find out about the philosophy of treatment. Because again, you know, there are very Christian-oriented residential programs that may be very helpful for some people, but maybe not for others. And then some programs too aren't as much believers in dual diagnosis, so mental health treatment as well as substance use treatment. And so depending on what are the issues going on with the teen, one type of treatment program may be better than another. So 7 challenges is actually an alternative approach to an alternative from the 12-step programs for teenagers that has shown to be quite effective, has been shown to be quite effective for teenagers. It's actually much more developmentally focused. So instead of the 12 steps, there's the 7 challenges. First one is to talk honestly about themselves, alcohol, and other drugs. And second is to look at what they like about alcohol and drugs and why they use them. And then to look at the impact of drugs and alcohol on their lives. Look at their own responsibility and responsibility of others for their problems. Thinking about where they are headed, where they want to go, and what they want to accomplish. And making thoughtful decisions about their lives and their use of alcohol and other drugs. And then lastly, following through on those decisions. So what's good about this is that it's much more future focused, which is where adolescents tend to be. So when they look at their drug use, to really have them focus on what they're not able to get or achieve because of their use. Frequently, it's the amount of money they've been spending. And so what could they have done with the money instead? They could have had their own car, you know, they could have had nicer clothes, you know, things like that. And that seems to be a better way to get at the resistance to change. So, and then the focus on personal agency and responsibility. So yeah, they may have family chaos, but that may be, but what can you do to help yourself? So how to talk to these kids? Non-judgmental stance is extremely important. Don't be a know-it-all. Because frequently, especially the kids who've been at this for a while, they may know a lot more than you do about what's out there and what its effects are. So acknowledge that. Acknowledge what they know, but also acknowledge that you're also an expert and this is what you know about the ultimate effects. And then acknowledge the good before focusing on the bad. So for example, if you're seeing a teen and the parent together and the teen is talking about how they were able to quit for several weeks on their own, but then the parent is immediately on the fact, well, blah, 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 you did this and this and this and this. The parent may also need some help in terms of acknowledging that, yes, the child tried and maybe need more help, as opposed to just immediately jumping on all the negatives. All right, it went backwards instead of forward. All right, let me see. Okay, so so educate, but know what's important to these kids. So for some kids, it's the grades. You know, they really are very proud of their intelligence. And if their grades have been slipping, that's something to help refocus them. It's okay. Well, it sounds like your grades have been slipping, and, you know, marijuana use has been shown to slow down processing. It affects your memory. And for some kids, that is what will hook them. You know, sports performance in, you know, other groups of kids is something that is very valuable to them. And of course, the adolescent brain, they have sex on the brain. I had one young man, after I was doing some education on how the chronic marijuana can cause fertility issues as well, he got this horrified look on his face, and he asked me, "Oh my God, can it cause shrinkage?" And so, I mean, that kind of tells you what the adolescent thinks about, right? And so when you know what's important to them, that's when you can help focus them on why it might be helpful for them to stop or cut down on use at least. So what happens without the formal treatment? So there was this longitudinal study of 122 adolescents with family history of alcoholism. And so they also started using alcohol early. 69% were able to achieve a year of sobriety without treatment. And they asked these kids what was helpful. So self-help efforts, so structured activities, school, working, family, new friends, all of these things were very helpful. And these kids rated 12-step groups as being the least helpful, probably for the reasons that I outlined earlier. So what do adolescents who receive treatment find helpful? So in this particular study, 167 adolescents between the ages of 13 to 18 were surveyed, and the majority of these kids used 2 or more drugs. 35% rated as positive outcome, with only 16 days of use over the year post-treatment. And then 65% rated as no negative outcome, average of 307 days use over past year. And again, what was helpful? Self-help, family, new friends, structured activity, schoolwork, recreation. Less helpful, so the old friends. So these were probably the using friends. And then 12-step groups was rated, again, less helpful. Some more clinical observations. First one, families with good prior relationships with their kids tend to do better. Now that probably makes a lot of sense. I remember one family in particular where the son started using marijuana in his senior year of high school. And dad, because they had such a good relationship, noticed there was something off about him right away. Confronted him right away, brought it into the treatment session, addressed it quickly. And because the son had such respect for his father's disapproval carried a lot of weight. And so after a month of use, he just stopped completely. And So the authoritative versus authoritarian style. Again, this father really demonstrated perfectly the authoritative versus authoritarian. So authoritarian is where you are very rigid, black and white, you do this or else, and very kind of punishment focus. Authoritative style is where, the parent is in charge, but they're actually pretty good at listening to their kids, and they lay down their law, but they're less black and white. They tend to notice what their kids are doing, and very quickly. And then they focus on the child, not just their friends. And then the friends thing, it eventually just, it falls into place if you focus on the child. The child really knows which friends are good and which friends are bad, and or bad for them, to reframe that. And when the parent overly focuses on the friends, kids also tend to dig in their heels. And also it takes the personal focus and the personal responsibility off of the child and puts it onto their friends, which the child actually resents, because as an adolescent, they want to feel like they are more in charge of their life. And so blaming it on their friends and telling them you just follow along is actually, it can make them quite angry. So the answer to the first question I posted, for me, adolescent substance users are just kids. And there's a whole host of reasons why they get into the use and abuse. And it's not helpful to think of them as delinquents or bad kids, or and so yes, they're just kids, and it's really important to remember that. Okay, so all right, thank you for listening, and any questions, I'll open it up. These are some of the references. The drugabuse.gov is actually a wonderful resource online. Not only do they have the Monitoring the Future survey results, but they have multiple videos and lectures and other resources for people who want to provide, education. They even have little choose your own adventure type videos available for teenagers to use. It gives them multiple choices through this video sequence. And it's kind of it's a fun way to do education on substance use. All right. Okay. So I'm going to stop sharing.
Right, thank you so much. Do we have any questions? Let's see, I need to make it so people can talk. You can put your questions in the chat or in the Q&A. And so everyone at this point should be allowed to talk. And if you think of questions later, you can definitely email me and I will forward them to Dr. Takahashi. I'm going to put my email address in the chat. So in conclusion, I need to share one slide, actually 2 slides. And so this is where you can actually get your CMEs. Do you see that? Is that showing? It has a QR code.
Yeah, it's showing.
Okay, it is. Okay. So if you have a smartphone, just point it up towards this QR code and
okay.
you'll be able to get your continuing education credits.
We do have one question.
Yes, yes.
So Suboxone is approved for kids down to the age of 16. And I have seen, especially lately, I've seen more and more teenagers who are requiring Suboxone treatment. Methadone, I don't believe that is used in adolescents. And I do not think Vivitrol is approved for adolescents at this point.
Everyone will also get an email with a link to the to where you can get your CMEs and do the evaluation. And I apologize, I have a really hard time sharing screens when I have dual monitors. So any other questions?
That was an excellent, oh my gosh, my brain just stopped on that presentation. I like it was specific to the teenagers. You know, at the beginning you said that it wasn't going to be strictly about OUD, but I really like this focus. We haven't really had a presentation like it, and it's super informative and I think really important information.
Well, thank you. You know, I know this was for the rural opioid prescribers, but like I showed in the beginning slides, opioid use in teenagers is relatively rare. And so you don't see as many teens getting physically addicted to it. And so you want to be able to catch it early, you know, and so this is really more about that, you know, in terms of just, they typically start with, you know, cigarettes, vaping, marijuana, alcohol.
Right. Yeah, no, I mean, I think it's an important part of the whole SUD and OUD training and information, because, you know, when we jump right into the middle of people who are already in crisis or having difficulties, it's much harder than learning how to recognize the signs early on. So thank you. Yes.
Yes, well, thank you, everyone, and thank you so much, Dr. Takahashi. So I see the QR code wasn't working, so because we hadn't ended yet.
Okay.
So we will, just be prepared to check your email for a link. So thank you, everyone.
All right, thanks.
Have a wonderful day.
Bye.
Bye-bye.